Hi, good afternoon. My name is Jordan Guice. I'm a surgery resident from Brooke Army Medical Center over in San Antonio. Today, I'm going to present survey results looking at general surgeons' experience levels and comfort levels with emergency neurosurgical procedures in austere conditions. Standard disclaimer, and we have no disclosures. So, as we know, traumatic brain injury is a serious threat to our men and women. One study reporting 20% of all combat injuries have an associated TBI. This could be from mild to severe. Another study from a Roll 3 hospital in 8 years of the heightened war revealed over 1,200 patients with moderate to severe TBIs, and then 40% of those underwent some sort of neurosurgical intervention. About 15% underwent craniotomy and craniectomy. So the purpose that we had in conducting this survey was what are the general surgeons' experiences and comfort levels in performing these neurosurgical procedures. And then we wanted to aim at what pre-deployment or post-residency pre-deployment training did they undergo, how did that affect their comfort level, and then what suggestions would they have in increasing their own personal comfort level. The way we did this is we created an online standardized survey. We distributed links to this multiple ways, trying to capture as many surgeons as possible. We targeted active duty reservists and those who had separated from the military. We targeted all three branches of the military. Austere environments were defined as combat and humanitarian missions, and then you can see our neurosurgical procedures defined as craniotomy, craniectomy, and burr hole. So what did we find? We found we got 205 responses that were eligible for inclusion. We had at least 398 separate deployments within our cohort. 20% had completed some sort of neurosurgical intervention. Of those who had completed one, 60%, the majority, had completed multiple neurosurgical procedures. And then only a quarter had obtained a neurosurgical consultation via phone prior to going to the operating room in these patients in which they did perform a procedure. That quarter that obtained a telephone consultation, 90% felt that it was helpful in management of this. So as you can see from this chart, as the number of deployments increases, the bottom axis over to the right, the percentage performing at least one neurosurgical procedure went. So the thought is that if you deploy enough, your chance or the odds of performing one of these procedures will go up. So a little bit of demographics on the injured. Penetrating injury was the most common. GSW and IED fairly similar as far as frequency. 73% had a GCS that was less than 8, and then the most common range of GCS was 6 to 8. And then some demographics as far as who they were. So host nation, uniformed personnel, and civilians made up the bulk. The rest were U.S. and NATO forces. And then 11% is actually of the total were children. And so in discussion or in trying to elucidate where and why they went to the operating room, 78% of these procedures, which were performed by general surgeons, were done at Roll 2 facilities. 3/4 were done without the use of a CT scan. They were performed based on clinical exam of the patient. And then when asked why they performed the procedure rather than transfer, the primary reason, 87% was that it was based on the patient's clinical status. 50% of that 90% also reported that there were tactical and situational factors that played large consideration. And then 2/3, 65%, said there was no neurosurgeon in the area of operations, indicating that this general surgeon was the provider to perform this procedure when it was indicated. And then looking at surgeon comfort. So a little bit less than 10% reported feeling very comfortable. This is a scale of 1 to 5, 5 out of 5 being very comfortable with just one of these neurosurgical procedures. Almost 4 times as many reported not at all comfortable, so it was a 1 out of 5 with any of these procedures. We also found that those who were most comfortable had a 2 times more likely to have post-residency neurosurgical training than those who weren't. And then in a free text box in our questionnaire, we asked them, what suggestions would you have to increase comfort level? And the majority mentioned more post-residency neurosurgical focused training. And again, in a free text box, 41% suggested cadaver labs, which were led and mentored by actual neurosurgeons. So overall, general surgeons are expected to perform these procedures in austere environments, whether they may be, and as I've shown, the majority of times, neurosurgeons are not around. So we believe in looking at our data from this survey that reliable 24/7 telephone consultation with a neurosurgeon would be a benefit to those surgeons who are trying to deal with these difficult patients with these severe TBIs. And then finally, we found that pre-deployment experiences vary greatly amongst neurosurgeons, and that we should focus efforts for including a neurosurgical focused cadaver lab taught by and led by neurosurgeons for our general surgeons who are out of their residency training. So I appreciate the opportunity to present today.